Everyone. Hope you are having a very good Thursday. Okay, so we'll get started. Maybe. How do I forward my slides?
You might need to.
Got it. Okay. So how did I get here? All right. So my undergraduate degree was in nutrition from Cornell. I then went to NYU School of Medicine. I did my internship at NYU. I stayed at NYU. And then many years later, I finished at Lincoln Medical Center in the South Bronx. So the path I thought that would get me from high school to medicine seemed very straight in my head. In fact, this is a picture of my brother, my older brother and I, and he's actually an oromaxillofacial surgeon and I'm a primary care physician. And I thought it would be a very straight shot, but life does not always work out that way. So my way to get to practice was actually sort of a little topsy-turvy. When I graduated from Cornell, actually when I was in Cornell, I thought I would have a major, and they make you declare your major even before you come. So there are different schools, and I was in getting a Bachelor of Science, and I decided to major in nutrition with the idea that I thought medical school would be at the end, but if not, I always had a fallback and would probably go into become a registered dietitian and maybe a PhD if medical school didn't work out. I took all my pre-med courses. The science base was actually a pretty good base because I got all my med school requirements done nicely. Biochem was included in my major, and I really did love my major, and it's proven beneficial throughout the rest of my career. So when I got into med school, I signed up and I went to NYU, and I went for a month, and I'm like, I don't like this at all. I'm leaving. And the school said, okay, take a leave of absence, you'll be back. And I was like, I'm never coming back. This isn't for me. All these people are too smart. But they were right. A year later, I took some time that year. I'd call it a gap year, but it was unplanned. And I really worked in medicine. I worked at Sloan Kettering. I worked at NYU downtown health center. And I found a great mentor who was like, you want to be a doctor. You can do it. Don't worry. And so I went back to medical school. I went through medical school. I actually got married in my 4th year of medical school, and I started at NYU internal medicine. And then life took another turn. I had a baby at that time, and I left practicing medicine for many, many reasons. And I actually went into pharma marketing for 10 years. At that time, I had a baby I was raising. I actually got divorced. And then 10 years after I stopped, I went back to my dean and I said, I think I want to practice medicine. And he said, oh, you're going to be genius. And I was like, really? I thought you would laugh me out of the room, but he didn't. And I reapplied to the match, and I matched at Lincoln Medical Center, where I did my 3 years of internal medicine. After that, I took the job that I currently have, and I'm still there 4 years later. So when you go into internal medicine, there are, a bunch of things to consider. First is, what kind of practice setting do you want? So you can go into outpatient, inpatient, which is a hospitalist work, or sort of this combination. I love the inpatient of residency, but I didn't see myself doing it all the time. And so what I did was I picked a practice that did mostly outpatient, but I still had admitting privileges at a community hospital. The other things to consider, in terms of what to do and where to get a job is, where did you train? Do you know people? Where's your family? Are you going to have support? I found in all of my training, having a good core of family around was really helpful. Again, when I went back, my son was 9, and I was a single mother, and my mom babysat him at nights, and it was incredible. I'm not sure I could have done it. It doesn't have to be your parents. It doesn't have to, but really close core support when you're in your training, because your time isn't exactly yourself. Then the other things after you're in internal medicine are, if you decide to go outpatient, what kind do you want to do? There are very few private practices, and in fact, that's sort of becoming a dinosaur where people sort of put out their shingle. You can go into large multi-specialty practices and practice primary care, and in different parts of the country, it's different. So I'm New York based, and a lot of the stuff that I know is New York. But most people will actually wind up working for a large hospital system. The last thing that actually sort of mirrors a little bit what I do is a concierge practice. And that's when you have a group of patients who join a practice for a certain amount of money as membership, and then they have a lot of access to you through email and your phone, and you'll admit them inpatient and see them outpatient. The other thing I'd say when you're considering where you want to go to practice internal medicine is, consider your colleagues, meet the people you're going to practice with. It makes a big difference. And I found always looking for a mentor. I found that going back to medical school, in medical school, my outpatient mentor was amazing. She's still a friend today. And then the first head of my practice was really a clinical mentor. Every time I had a question about a rash, he was absolutely there for me. All right, so what does my practice look like, and what is a traditional practice? It's called a traditional practice because it was the way medicine was practiced for a very, very long time, where you did everything. I see patients in my outpatient practice 3.5 days per week. I round in the hospital about a half to a full day a week in a community hospital. I'm on call every fourth weekend where I round for my group on Saturdays and Sundays. And we have hospitals coverage, so we don't admit after 5. That's the only real way to do a traditional practice, so you're not in the hospital all the time. And I also teach. Our community hospital became affiliated with Westchester, which really was such a blessing to me because it was something that I never thought I would do. And I was so thrilled when I was able to do that. So one of the things, a couple of things that I truly, truly love about my job is the time alone in the room with the patient or in the hospital. I feel really blessed that these patients are allowing me into their life. And I ask question after question I'll ask about sexual activity, how much they drink, what's their job, how are their children. And someone once told me, no question is off bounds when you're a physician, because usually it has meaning to their health. A lot of times I have people who are married for a very long time, and I ask, are they sexually active? And some people get really uncomfortable. They're like, oh, I'm married. And I said, okay, but that doesn't mean that there's an answer, the right answer. And sometimes it actually tells me a lot about the relationship that these people have. People with closeness have intimacy. If they're not, I ask about, physical problems, vaginal dryness, that could lead to another conversation in men. Is there erectile dysfunction? The other thing I love is, one, I see a lot of the lifespan. So I start about 17 and go up to my oldest patient is 106. And I love seeing anxiety. Oh, by the way, anxiety goes through the whole life cycle, but people starting to become sexually active, getting into relationships. People have anxiety about going to school. Will they live up to their parents' expectations? As you get a little older, I watch people as they get pregnant with their first baby or, struggle with infertility. You see them in long terms of their marriage, their children growing up, major events, weddings, confirmations, all things people are excited about. So really, I could have a million different scenarios in my office during the day, and it's amazing. The biggest thing I think I love about my practice is there's a balance. So I'm not outpatient every day. The flow to the hospital is so different. It's not as timed as my outpatient. I could take more time. The other thing I like about it is I get to see my specialist. So people I refer to, people I share patients with, we can catch up. I can see them in a setting to know how good they are, to know how they talk to their patients. I've stopped referring to some people as I've seen them in the hospital, really not give time of day to patients or answer questions. And I think the biggest thing that I really, truly love about my job is at the end of the day, if I feel that I've connected or made someone feel better, whether it's physically, which oftentimes can happen with a sinus infection or a UTI, right? Or I listened. Sometimes we can't fix the problem, but you're available, you're their outlet. So, all right. So what does my outpatient day look like? So these are my medical assistants standing behind me. And I'll tell you that nothing could be said more about medicine. That is a total team sport, inpatient and outpatient for both. And so this group, they room my patients. I usually do a lot of training with them up front on how I like my patients roomed and what I like, because it makes me so much more efficient when they are good at their jobs. I also like them to get invested, so they know the patients the next time, everyone feels comfortable, and there's a real team approach. The other people in my outpatient office are, the office staff. Sometimes this is a little bit strange. I've often heard people unhappy with the relationships, how people answer the phones, what kinds of answers they get to the questions. And for me, that's very meaningful. I want the patient to have a really good experience from start to finish. And so I try to make sure as much as I can that everyone listens to the patient, is polite, and sort of things. We have prompts, it's really annoying. So stuff like that. And then we have other people who do, prior authorizations, call the specialist and stuff like that. So that's my outpatient practice. My outpatient practice is a total mix. I do a lot of annuals, Medicare wellnesses after people hit 65. The annual changes as you get older because you want to include questions like, who's their healthcare proxy? What do they, if something happens, who's going to make the decisions for them? And then other things like, if they're sick, do they want to be resuscitated? Do they want to be intubated? And questions like that. All right. And then so inpatient is, again, a little bit different. We have a much bigger team. And the care is much more acute. So the patients come in with a real, an illness, whether it's an MI, they need an appendectomy, congestive heart failure, all things like that. And the team I work with there are nurses. In my office, they're actually medical assistants and not nurses. But in the hospital, they're nurses, they're care partners. One of the women in that group is physical therapist, and they're case managers. This week, I had a long-term patient who I've been seeing for 4 years who had come into the outpatient practice. He actually came in for a swelling in the groin. I had seen him a couple times in the last couple of months. He had fallen. He has Parkinson's disease, which causes tremors all over, and he had an unsteady gait. He had fallen and came to our ER and needed his face stitched up. He actually is in his 80s. His wife is 10 years older than he is, but he looks 10 years older than she looks 10 years younger than him. So it's a very interesting mix in the dynamic of this group. And so at one point, I got him after he had fallen and I needed to remove his stitches, which I did. It was actually a very odd thing because I almost had to give him a facial because they hadn't washed the stitches and I had to get the dried blood off the stitches in order to remove them effectively. And that was one visit. He needed to follow up with his neurologist, had kept missing appointments and didn't do that. So the next visit, his wife wanted him placed in a nursing home because she was having a real difficult time taking care of him at home. And she would call me multiple times and they finally came in and she says, I can't do this. What should I do? The thing is, he's had full competency, so there was nothing I could do. And I told her that, and I had to have a conversation with them both. He says she nags me all the time. And it was like almost a marriage counseling session. And I said, Zeta's love language is nagging you because she's worried, and your love language is buying her gifts, and we have to meet in the middle because you guys are really not supporting each other at now, sort of thing. So the next visit, he comes in for his annual, and she says, can you check? He has this really big bulge on his left groin. So I said, okay. I was doing his annual anyway. And sure enough, I examine him, still tremors, Parkinson's, hypertension, but he has this very hard mass in his left inguinal area. And I've diagnosed testicular cancer before, and this felt like it wasn't in the testicle, it was in the inguinal area, but it felt very hard. At first I thought surely she was talking about a hernia, but it wasn't. So what do? He's in my outpatient office, and I discover a real big mass. So I get on the phone and I call a surgeon and I say, he needs this removed. What should we do, sort of thing. And the surgeon and I, set him up for an excisional biopsy and a PET scan just to see if something, there's cancer other places, if this is actually cancer. We weren't 100% sure. So a week later, he's supposed to go for his excisional biopsy, and I get a call. He's fallen off the couch and he can't get up, and they need help and they can't get to the surgeon. So we call EMS, they get him back on the couch. They're refusing to go for the excisional biopsy, but the PET scan came back and lit up many places. It's called FCG ABID. It's nuclear medicine. And when there's a high metabolic area that lights up, it usually means cancer, secondary, the high metabolic area. And he had a few places, one in the inguinal area, one in the colon, and a few other places that I don't remember. So missed his excisional biopsy, and I have a good long-term relationship with both of them, and I call them both and I say, okay, get in the ambulance and come to the hospital, because he really needed the workup and he was failing. He had lost 20 pounds over almost a month. Like, there were not good signs that this was going really kind of poorly. His functional status was getting worse. He was having multiple falls, and I just felt he wasn't safe at home. We brought him into the hospital, right? And then one of the nicest things about a traditional practice is when a patient sees you in the hospital. Because if you think about how scared they are, how many people they don't know have seen them in the ER, have taken their vitals, have taken their blood, have taken their clothes. So, one of the joys of my job is walking to a hospital room, and now it's with masks and PPE. And so sometimes they don't even recognize you, but it's this feeling of relief. And that's what I got. So he had the excisional biopsy, and we were waiting for that to come back. Although I had looked with the pathologist under the microscope before we sent it out for staining, and it looked like a large B-cell lymphoma. But I wasn't quite done, because I knew there was something in his colon. Now, colon cancer doesn't usually metastasize to the lymph nodes in that groin. So it was very weird. And his PSA had been normal. So I sort of ruled out prostate, which again doesn't go there, but it was a large B-cell lymphoma. But, so anyway, we kept him in the hospital, and I wanted him to have a colonoscopy, because I figured if there were another cancer, or it was lymphoma, there was whatever was lighting up was lymphoma in the colon, the treatment would have been really very different. So had a colonoscopy, has an ulcer an ulcerating tumor in the colon. We get the colonoscopy, and it turns out that he does also have adenocarcinoma. So we did a laparoscopic removal of the adenocarcinoma and put in a Mediport yesterday, and he'll get outpatient chemo. So, this is just one case that you see sort of pull through from the outpatient to the inpatient setting. And there's a lot of, first I can speak to his wife. I've called her many times over the weekend, just watching how he's doing, making sure she's okay. She also happens to be a patient and needs a lot of support as well. And sort of, knowing you're involved is helpful. There's not a lot of social support from their family. So that's my current practice, is this mix between inpatient and outpatient. November of last year, I was, doing well in my practice, but, oh, sorry, I did something wrong. All right. How do I get my poll closed? Sorry.
You can just X out of it. The top left corner of the poll box should have the red X, or you can just move it out of the screen.
Okay. Can you, okay. I think I did it. All right. So a while ago, I had this good idea, or I thought it was a good idea. What was happening in the hospital was when I was doing end of life conversations with patients, I used a group of nurses who were called palliative care nurses. And then we have 2 in the hospital, and they're actually really good at their job. But they were getting a lot of resistance from hospitalists who were admitting patients. When a hospitalist admits a patient, they really don't know the patient. They just get them based on who's up and whose time it is, sort of thing. And we also found that some doctors, instead of having difficult conversations, were letting patients sort of go the route of having a tracheostomy and a peg tube, and ultimately going back to a nursing home and sort of living out their life like that. Sometimes families want that, and if that's what the family wants, and if that's what the patient wants, that's great. But I also felt that sometimes physicians were putting their patients through sort of extraordinary measures without really good conversations. So I went to the CMO of the hospital, and I, sort of talked about what my interest was in palliative care, and where it fit, how it would benefit the hospital in terms of cost and things like that. And he agreed, and he got it through something called the medical executive committee, which always is needed to change anything in the hospital. And that's what he did. And I started doing that in November of 2019. I had been training for the New York City Marathon, and I was raising money for the palliative care group. And that's all these long runs were sort of getting me excited and thinking about how I could do more for this specific interest. So then, as you know, sorry, now I'm really messing it up. Okay, so as you know, then 2020 hit, and it was good that I had started practicing palliative care, doing notes in palliative care. We're getting my language down, how to talk to parents, how to talk to families with difficult conversations, because all of a sudden New York became the epicenter of COVID-19. And the second week in March, I think it was, I was on call on a weekend. And so I was rounding, and we had the idea that this was coming. And I was back in my office that Monday, and I have a very good friend who works in the ER, and she's like, Lisa, Christie's, who is a critical care doctor, is about to call you. She needs you to come in. I'm like, what? Okay. So the critical care calls me, and she says, we just intubated 6. We're not sure how many ventilators we're going to have left. Some aren't going to make it. We need you to call the families and see if we can take them off, because we are afraid that we're not going to have enough ventilators. And this was the start of, I think I did 7, if not 9, I can't quite remember, 9 weeks of inpatient medicine in the hospital. And it was one of the weirdest things to ever happen, because medicine, you're usually taught, you usually have an expectation of what it's going to be like. And now we were in, as you all know, and you're in it too for your lives, this very strange place where we're about to run out of resources in the United States. I almost never thought that would happen, but we were. And so I just want to point out, a few things that sort of helped me when this happened. One was, there was one day when I was home and I was watching the news, and it was a miserable day. I realized once I set foot back into the hospital to work, I was better prepared emotionally. I could deal with it emotionally. So the feeling of being needed, an essential worker was really important to me as a person. It was going to be hard to sort of watch this all from the sidelines. I think the other couple things, one is the community. The nurses called when they needed, because I do so much palliative care. I have no problems giving pain management, morphine for dyspnea. We saw a lot of dyspnea we had to have conversations with patients' families that they weren't doing well, and they weren't able to see them. At times, you just were in the rooms, kind of giving them human touch, human contact that they didn't have. Some of the best people who did it were the people cleaning the rooms and made sure to say hello, because it was lonely. We tried to FaceTime. We tried to do music that they liked. We couldn't be happier when someone left. It was applause and stuff. And on the days I took off, I checked in on the people who were in the hospital, the other staff and stuff, and we wanted to know what happened to the patients and things like that. So I was really happy to also sort of be of service and have skills that could be used. Some of the things that were hard were fear. I'm not sure I ever felt that I was putting myself at risk. TB, finger sticks, things like that sort of are rare. When I'm working, there was a lot of loneliness. Even though we were in teams, you'd go home, your friends couldn't understand what was going on. Some people wanted sort of just to talk about it, and it's kind of the last thing you wanted to do. And the other thing that was really tough, and I think is still hard, is this feeling of mistrust, that there's a science mistrust and things like that physicians were making money off COVID diagnosis. I'm not sure many people go into medicine for the glory. If you were going into for the money, you better have a very specific specialty. You do it, or I did it, to help people, to serve people, to be useful. It's not always good news, but I think that death isn't the worst thing, suffering is, right? And so that's sort of some of the stuff that I keep in mind. Sort of thing. And, it looks like we think we may be on a second surge. And, I've checked in with my nurses they're really burnt out, so, it's going to be a weird time in healthcare, certainly. So, we'll see what happens. All right. All right, so some of the traits that I think are helpful in my practice, one is empathy. So like I said, I had taken a very circuitous route to finishing my medical education and my residency. And so I think sort of taking a step back, having other experiences helped me refine my empathy. It helped me understand when people talk about their children, and you don't have to have children to understand how people talk about your children, but you want to sort of put yourself in what they're saying. I've had a few patients who've had children who've committed suicide. It's, the statement you can't move on from. You want to show them empathy and understanding. You want to make goals, but again, you don't want to disregard what's meaningful to the person in front of you. So next two, intelligence, I think, is clear. If you're going this route, you're going to be intelligent. You're going to get with a group, you're going to be educated with a group of intelligent people. But on top of that, you need emotional intelligence. You want to look at some of your biases. You want to tune in to what people are saying. I have people come in maybe 30% of the time that have a physical illness, and they are sure it is physical, and it's not. It doesn't make sense. The shortness of breath, where they can't quite get a deep breath, or that feeling that something's stuck in their throat, heartburn, palpitations that come and go, sweating in their palms. So you want to rule out any physiologic pathophysiology, clearly, but sometimes, you just get to a point where everything hurts and it's probably something emotional, and it's hard, and some people aren't going to agree. And some people are going to push back and say, no, but I feel this so strongly, it must be physical, right? And you sort of want to have that intelligence about it. One of the other things I would put in intelligence, emotional intelligence, is your bias. So if you're a vegetarian and you think it's the best thing in the world, it's hard to make everyone a vegetarian. So, you want to sort of be careful and listen to the patient and what they say. The other thing, I find organization really helpful. Obviously, you just have a ton of things to do, billing, notes, stuff like that. You want to come up with a system that's good. So when I teach my medical students, we go over systems for their EKGs, rate, rhythm, axes, their timing, and then look at the ST. So you want just organization when you do anything. And for you guys who are studying in college, I'm sure the more organized, the better you are. And even in medical school, it's going to be really important. My brother, who actually went to the same medical school, and we used to say we'd do things 3 times. We'd either read it the first time or go to class and hear it the second time, and then write notes on the class ones the third time, and then you review it for the test. You just need a system and stick with your system once it works for you. All right. And then the last thing is you want to sort of not always check on you want to sort of back up and look at the big picture on patients. So this specific patient that I talked about who had lymphoma and colon cancer, it was a hard choice. Oftentimes if he had a poor functional status and a bad quality of life, I'm not sure I would have put him through any of these things, right? So a patient who had multiple MIs in a year, you may want to not go for invasive surgery. You want to just make sure that maybe they want to be home with their family or not. Maybe they want to be in hospice or things like that. So sometimes winning a small war doesn't get where the quality of life is. And I often talk to patients about quality of life and stuff like that. And I start pretty early on resuscitation, intubation, who should make their decisions. Everyone has a right to their decisions. You just want to know what it is, because when you come in an MI or a horrible car accident, no family member is making a rational decision. So it's good to have the early conversations and get everyone on the same page, especially if there are multiple siblings or multiple decision makers. It's always helpful to say, your dad said this. When we were in the office and he was okay, he said this. Do you know something else? Have you ever had this conversation? Stuff, things like that. All right, sorry. All right, so, some of the stuff I think I sort of talked about, but one of the things I always talk about with my medical students is you want to meet the patient where they are. So if you come in, you say, oh, you're here for a sore throat, right? Because your MA told you, do you have a fever? Do you have this? Do you have that? You're taking control, which isn't always bad if you're busy, but you sort of want to start with an open-ended dialogue question. And I always say, why are you here? What's going on? And I try to not interrupt for a long enough time that they can tell me the story. The studies show there's an efficiency for that, to let them tell their story. And some people, by the way, will start with something totally different than what the real problem is, but you sort of round back. And then in my outpatient, oftentimes I'll diagnose. So like I talked about anxiety, right? So the patient comes in, waking up early in the morning, chest pain. When they're driving, they're concerned that their parents had coronary artery disease. You do an EKG, it's totally normal. They're also 21 with no risk factors for hyperlipidemia and this, hypertension. So, I kind of come down into it's anxiety, right? Then you have to educate them on anxiety, why you think it's anxiety, why, some of the other things, because if you're going to treat them then for anxiety, you want them to sort of buy in, right? And not think, oh, I need another doctor who knows something about me, right? This also comes up all the time when people come in for a sore throat or an upper respiratory infection. And they say, my last doctor always gave me a Z-Pak, and that's exactly what I needed. And, chronic bronchitis is a virus and doesn't need a Z-Pak. So, you sort of want to move the patient away from that and say, it's rest and decongestants and things like that. So I try to educate. I'll take the time to do it. I always think it's worth it to do that, because I feel that people come to me for good medical care and not necessarily checking off their boxes of what they want. If they were able to treat themselves, if they were a doctor or something like that, maybe it'd be different. But sometimes what people want isn't always what's best for them. All right. Yeah, I think I'm going to wrap it up there. Yeah, I mean, I just have like a few more slides. One is, when I was building my practices, I would go into the community. Two of my popular ones were preventing dementia and losing weight. So, yep. And then, yep, any questions?
So great. Thank you so much. You were so inspiring. If you open up the chat, you can just see all of the messages pouring in your way. Some of my favorite quotes were, "You're a true saint." And
Where do I see that? Wait, how do I get that?
people are very happy that you decided to go back into medicine and wish that every physician was like you. So thank you so much for sharing all of this. There were lots of good questions, so we'll try to get to some. I think one of the main questions that people had for you was, you talked a lot about palliative care and end-of-life care now with COVID. How do you yourself emotionally deal with that? Is there a burnout? How do you deal with it?
So, like I said, I ran the marathon last year. Running became like breathing, and in the pandemic, even more. So I actually woke up every day and went for about a 10-mile run, because I wasn't sleeping well. I wanted to get my jitters out before I was about to walk back in the hospital. Everyone has good and bad coping mechanisms. The earlier you develop your good ones, the better off you are. At the time, my eating wasn't great. The community was just sending in tons and tons of food, which was amazing because we felt so supported. And the only time you took off your mask was to have the food. So you didn't want to stop eating to put the mask back on, sort of thing. There are two different things about palliative care. One is palliative care with the patients that you know really well. That's the hard part for me. Isn't that the patient has passed away. It is sadness of the family and myself, right? Like, I will miss them. What's happened is every time a patient passes away, I wind up getting 2 more patients. And I think the reason is the family feels so connected to you that you were there when it was bad, right? And that's an incredible feeling. And then the family comes back for their annuals or whatever, and we talk about that patient. We honor that patient. I have one patient now. He was the sick one, and his wife was the caregiver. And at some point, she got a really bad neuromuscular disease and did really poorly pretty quickly. And he survived her. And he came in one day with dizziness. I had a med student go in and meet him. And he says, he has dizziness. And I'm like, okay, what do you think it is? And he's like, BPPV. And I'm like, okay. So I'm like, hi, blah, blah, blah. How are you? What's going on? And he goes, I'm having dizziness. Like when I stand up and walk in the car, I'm like, okay. And he goes, and look at this. And he shows me his phone, and there is a toilet full of blood. Right? So I look at the med student, and this is like so typical, by the way. The med student's like, he didn't tell me. He didn't tell me. I swear he didn't tell me. Right? So don't feel bad, because it happens to everyone. So the patient being the patient, and I say, okay, you have to go to the ER. He's like, no, I'm not going to the ER. I was just there, and he was for CHF a couple weeks before. So I'm like, I'll get you a stat blood work. I'll call you tonight. If I tell you to go in tonight, you're going in. Fine. I get the CBC. I actually didn't get it that night, but I got it the next morning. It dropped a lot. So I called, and I know the family now well enough, right? I called him. I'm like, call your daughter, call blah, 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 and tell her to come. You're going to the hospital. And he did. He went to the hospital, and then he's refusing the colonoscopy in the hospital. So I say to him, hey, listen, I am not having this with your 3 daughters, and Judy passed. You think they're going to go without a parent? Judy is sitting on my shoulder yelling at you that this is the stupidest thing she's ever heard. So get the prep. This is over. We're done talking about this, right? The cardiologist had the similar talk, except without invoking his wife, his dead wife, right? That's one of the things. Even when people pass away, sometimes their quality of life was bad. She really declined really quickly, but we honor her memory. I still have a plate from her. She left me brisket in the office one day. And we talk about that. We talk about it with her daughters.
That's awesome. That's also funny. People were laughing at how you just snapped them. That's awesome.
Oh, it's tough love often.
That's so funny.
I'm also like a sort of straight shooter with my patients, with my med students, with my staff. Listen, medicine is hard. You want to explain it well, and you don't necessarily want to give them what they should do. Like, if there's an option, you want to give them the option. He was going to do fine with this colonoscopy. The only way to know what was going to happen was the colonoscopy. He was just being pig-headed. So
that's so funny. There were a lot of questions earlier in your talk when you were talking about finding a mentor. And people have a lot of questions about, how do you find a mentor? Is your mentor another medical professional? How do you reach out to people? Because a lot of us feel like, doctors are these ethereal human beings, and if they're so hard to talk to, or just how do you kind of make that push to get a mentor?
It's hard. So it's hard to walk on the street and be like, hey. What I would say is a couple things. One is you don't want your direct boss to ever be your mentor. You need to be able to talk about that person, right? You want it a little bit removed. You want to go out and get a lot of experiences. You want to shadow people, do internships. It may not be a medical person, but a leader in another field that you are doing volunteer work. If you follow your passion, people with similar passions are going to be there. You'll click with someone. Recommendations, they're hard. Your teachers and guys, in this time and place where you're socially distanced, I can't even imagine. I mean, one of the things that came up that I did sort of and fell into was social media, right? Like, no idea. I was opening a new practice in Orangeburg. After 3 years in the old practice, they were doing no marketing, none. They just were going to put me there and see how it went. I'm like, okay, what are you, crazy? So I went on social, because the group I thought we were trying to track was Instagram age, not Facebook page, but Instagram age, right? Because there were 3 colleges down there or whatever. So I started on Instagram, and let me tell you, I'm not sure it helped my practice at all, but the connections that I've made are amazing. I mean, I find people who inspire me, right? Renee Paro, who I think has done yours, and she's like, I want to be in your talk. I'm like,
he was on here, yeah.
Right? Like, I have a girl, like, I'm listening to Obama's book. Like, it's amazing, like you have to just put yourself out there. And by the way, if you don't ask, the answer is always no. Like, listen, I failed look, you saw me. I failed multiple times in my journey to becoming a doctor. I also got up and brushed myself off and said, what, I screw up that time? Sometimes it's not the worst. It's actually build strength. And for me, it tapped into the steely motivation that was going to get me through no matter what.
There's people saying that you should definitely write a book or start a podcast because they want to listen to you all day. And I agree.
Listen, my son is gonna come in. He's I was told no TikTok early on. He's my social media conscience.
That is awesome. So back when you were talking about being in the pharma industry before getting back into medicine, what was it, an experience that you had while you were working in that industry, or what was that push that you decided to go back to med school?
I got fired. I was like, what? So it really just, there were some really good creative things. I made some really good friends who just thought with a totally different brain than I did. I was all science, like I could tell them the pathophysiology and the mechanisms of the diseases. And then we would sit in a workshop and they're like, well, what's the personality of the drug? And I'm like, what? And they're like, is it is it warrior princess? I'm like, okay, it's a drug, right? Like, not a person. What are you people talking about? But it was fun. and I traveled a ton, and it was really nice. It was a lot of time away from my young son. And there were different stresses. It wasn't life and death stress, but we lost an account, new business was stressful. And I found that people would come and ask me medical questions, and that's kind of what I liked. I liked the interactions amongst people. I hated public speaking at a point, and then you just man up and you do it all the time, right? And so that's why I don't mind at all now. You do it over and over. When I started my internship out of med school, my first one was an elective. I'm like, oh, great. And I did 2 weeks of palliative care and 2 weeks of pain management because I was afraid someone would die and I was afraid someone would be in pain. And I figured, let's go, just give me some skills so I can know what to do. And then going back, I became an EMT. So after taking time off, I'm like, oh my God, I have no medical brain. Like, I know sort of some stuff, but so I became an EMT. I was the worst EMT in the world. Like, I don't know if any of you guys are EMTs, but that stair chair. And then they're like, and when you're, after a few years, you're going to drive the ambulance. And I'm like, people will die. I'm like, everyone will die. No one will live. I'm like, that is not a good idea. And so I was like, I think this isn't for me. So I went, but, and then I have to say, my dean was super amazing. I walked in, I was like, he's going to laugh me out of here. But it was one of those situations where I had to suck up my pride and ask for help because I wanted this. I knew I wanted it for years and years. I felt like I had given something up. The other weird thing about it is becoming a mother put my backbone back in place because I would not accept this from him. Like,
that's awesome.
Yeah. I mean, and so all of a sudden I'm like, oh my God, I better model correctly.
Yeah, there's some EMTs in the chat, so they're agreeing with you. They think that's all funny. Kind of switching to internal medicine questions. Someone was asking, what kind of procedures do you do as an internal medicine physician? Is it more of just like, do you examine patients and then call their specialist, or do you yourself actually do procedures as well?
So it's very limited. For me, it's very limited. Don't forget, I'm in New York. And so like people love farming out their organs to specialists. It drives me a little bit crazy because I find there's no continuity. And as the nephrologist is going up on their LASIK, as a cardiologist going up on their LASIK, the nephrologist is like, why is your kidney function going so badly? So good communication is key. I do a couple. I do I&Ds, incision and drainage. If I can, perionychia removal, I'll do. Some of my partners will not. Every now and then I take off a skin tag, not much. You'll find, but we should know, internal medicine is the gateway to other specialties that do procedures, right? So cardiology, endocrinology. If you ask me, internal medicine is no decision at the end of medical school, right? Because then in 3 years, you'll make a decision again. Are you going to go into cardiology? If you go into cardiology, do you want interventional cardiology? If you go, you can go into GI, which does colonoscopies and EGDs. So a lot of things like that. Yeah.
Great.
So I don't do all that many. I would have done pap smears in the office. I had trained on that. The reason you don't is you get a lot of referrals for your gynecologist, and if there's a problem, you have to send them anyway. So it's kind of more, that's inefficient.
Awesome. Thank you for answering that question. Also, there are some people wondering what do you think about the DO route to internal medicine? Is something you recommend? Do you work with any DOs in internal medicine?
I totally do. My favorite endocrinologist and her husband are both DOs. She's an endocrinologist. He actually does like kind of not sports medicine. I forget what it is. Not sports medicine, but he actually does DO stuff that's specially learned in DO school of manipulations. Whenever I have a back pain or some muscular pain that I am sort of at wit's end, I've tried physical therapy, I've tried NSAIDs and muscle relaxers, pain management, I'll send him to him. He has acupuncture in his office, which I think is a great, I'm not sure. I don't believe in alternative medicine, I have to say, because I don't think there should be an alternative to proven medicine, right? But, you know, acupuncture, you know, there are 1,000 ways to get what you want. If you don't think out of the box, someone's not going to do well.
Yes, thank you.
And yeah, so for me, DOs are no different because they all do residency. So much of what you learn is in residency for what you're going to do for the rest of your life. You know, medical school is great. You get exposure to everything. You make a choice, and then you really go and learn it.
Mm-hmm. And then kind of bouncing off of that, how often do you work with PAs and NPs? Are they a big part of internal medicine as well?
They are. We used to have an NP in our office. PAs, I find in New York at least, a lot of times are with surgical specialties, although we had a PA who worked with our cardiologist. I have like a lot of feelings about it. I think there's a place for them in medicine. I think I'd like federally for there to be more definitions of what is what. When the states regulate it, a lot of times it's about access, but I'd like it to be about training more than anything. NPs ask all the time if they can shadow with me. Occasionally, not so much PAs. I think PAs are more set in their curriculum, but NPs sort of need people to take them on. I don't do that anymore because I teach medical students. And the issue is, you know, sometimes you feel like they're a cheaper alternative. You know, the administration sort of makes it like, well, they're the same as you and they're cheaper. And in some things they're wonderful. Like they're really good. We had a nurse practitioner who did infectious disease for many years. She was excellent in our outpatient office and she was great, but she had years and years of nursing experience before she got her nurse practitioner. You know, I find some people speed through nursing and go straight into a master's or whatever it is. And the thing they're missing is the residency. Like, listen, give them 3 years of residency, we'll talk, you know, but one of my closest friends, an ER physician, sometimes we get this, we call it our spidey sense, like something's just not right about the case. They come in and they're like, I have a hangnail. And you're like, okay. And you look for the hangnail but there's this, you know, this hacking cough, you know, there's something wrong. Or there's a hanging bias, right? Someone presents the whole case to you for you know, this and this and this, and then they tell you all the reasons it's what they're saying it is, right? And then you're like, well, what about this? Did you get the chest? What is a chest X-ray? You know, something like that. And you're like, or a number is just wrong, you know, and you're like, something is, or you just look at them and you're like, they're so much sicker than they appear on paper. Why? Something's not right. And that just takes a ton of time. That just takes experience.
That's good to know. Thank you for that. I think, so we're going to wrap up here. And our final question for you is, what piece of advice would you give us pre-med students, college, post-bac students in our journeys, especially now during the seemingly never-ending COVID?
Yeah. So one, you know, I'm so sorry. Listen, it's tough. It's tough for you. It's tough for everyone. You have this feeling of loss. But there are a few things that I've been pointing out to my patients, certainly. So one is gratitude. Just look at what you have. Look how much you have. Look how much you can learn. Look, you put together a whole program to get through a problem, right? It shows resilience. You know, a lot of young people don't have to learn resilience because their path is super straight. And those who aren't sort of have at the end of it a feeling of gratitude that, yeah, it didn't go the way it should have, but I'm here now and I'm psyched, right? It wasn't easy, but sort of thing. That's one thing. The bigger thing I'd say is keep good habits. Make sure you're going into your good coping skills. Like for me, it's exercise, it's running, eating better, try and eat better, try to have a schedule. So even if you are online at school and there's no schedule, you want to go to sleep the same time, wake up the same time. Sleep is super, super important. When you study, try not to do 12 hours, 6 hours at a clip. You know, you want to do an hour and a half, get up, do something else. clear your brain so that you can make those memories as well. You have fun, try to enjoy the place you are at the moment. If you keep looking forward, you're going to miss so much, because most of you will get there anyway. So enjoy what you can in the place you are. My med students have the hardest time with this. It's, like, I'm like, okay, I mean, and I'm hard on them and I want them to learn, but I also want them to remember to, exercise and make time for their friends and their family and find things they enjoy. It's a long hours of the day. You'll get everything in, but prioritize the important things.
Thank you so much. I think that it's definitely hard to remember to be grateful. So that's a good reminder to be grateful for what we have. Thank you so much for joining us today. You were absolutely amazing. We all loved your talk so much. Like I said, if you open up the chat, it's just praise and praise and praise coming your way. But thank you so much for giving us your time this evening. We hope you have a great rest of your week, and please stay safe at work.
No problem. Thank you so much for having me. Good luck, you guys.
Thank you. Bye. And then Dr. Hirsch's info is on the screen if you guys want to get that down. Great. Thank you.
Have a good night.
Bye. You too. And then